My name is Ilianis. My topic of Romosozumab treatment in postmenopause women with osteoporosis. Definition: Menopause, the natural cessation of menstruation that usually occurs between the year 45 and 55, may increase in women with developing osteoporosis. Eye condition and weak bone because the fracture reacts. The drug is strongly weak that produced around the menopause start result in increased bone loss. It is estimated that women lose averagely of up to 10% of their mass the first 5 years after menopause. Romosozumab is a drug that acts directly on inhibition of secretory protein activity. As a result, the blood protection effect of bone increases inflammation and reduces degradation. Video.
After the age of 30, bone resorption will slightly exceed formation, and bone mass begins to diminish. In women, this can become even more of an issue following the onset of the menopause, where declining estrogen levels further increase the rate of bone resorption. Osteoclasts are regulated by various signaling molecules, including rank ligand. Rank ligand promotes the differentiation, activation, and survival of osteoclasts via an interaction with its receptor, rank. Once activated, osteoclasts resorb bone. However, the hormone estrogen is thought to repress rank ligand signaling. Downregulation of rank ligand expression leads to decreased activation of rank and a subsequent decrease in osteoclast-mediated bone resorption. Estrogen has also been shown to stimulate the expression of osteoprotegerin, which inhibits the activity of rank ligand by preventing it from interacting with its receptor. Following the onset of menopause, estrogen levels start to decline. This can lead to increased rank ligand production, which is associated with increased bone resorption in postmenopausal women. Increased bone resorption after the menopause leads to the accelerated loss of bone mineral density, which can result in the more severe condition of postmenopausal osteoporosis, in which the skeleton becomes increasingly susceptible to fracture. Vertebral collapse is often secondary to osteoporosis and is more prevalent in women. In osteoporosis, the thickness of both cortical and trabecular bone decreases over time, suggesting that both of these structures play a role in the development of vertebral fractures. These events, such as fragility fractures of the hip or vertebrae, may contribute to the painful and debilitating
Application in nursing. Avoid high-impact activities or those that require visible movement. Do weight bearing exercise, such as walking, dancing, and weight training. Do aerobic exercise 2 or 3 times a week. Carry out strength training once or twice a week. Include flexibility or strength exercise immediately. Video. and cons. Advantages. Administering the drug Romosozumab for 12 months to postmenopausal women with osteoporosis has managed to significantly reduce the risk of better effect. The effect of Romosozumab on the risk of vertebral fracture was rapid with only 2 initial vertebral fractures. Out of total of 60 fractures on stipulated results overall occurred during the second 6 months of streaming. Disadvantages. The most common fracture association with the postmenopausal osteoporosis occurs in the heel, spine, and width. About 30% of postmenopausal women suffer from osteoporosis, and as a result, at least 30% of them will have one or more fractures during their lifetime. Vertebral fracture can result in several bones, pain, and deformity. Video.
Our topic today is about denosumab treatment of osteoporosis in postmenopausal women. Osteoporosis is a disorder of the skeletal system characterized by compromised bone strength, predisposing patients to an increased risk of fractures. The receptor activator of RANK is expressed on osteoclasts. The interaction of RANK with its ligand is the final common pathway through which bone resorption is regulated. By binding to its receptor RANK on osteoclastic precursors, RANK ligand controls the differentiation and survival of osteoclasts. Osteoclasts cause bone resorption and breakdown when osteoclast activity exceeds osteoblast activity. Over time, osteoporosis occurs. Menopause causes a decrease in estrogen levels, resulting a decrease in bone strength and an increase in bone resorption, leading to possible fractures. 80% of people with osteoporosis in the United States are women, and 1 of 2 women older than 50 years will have a fracture due to osteoporosis during her lifetime. Women with osteoporosis who are considered to be at high risk for fracture include those with previous osteoporotic fracture or multiple risk.
In su application in Ecuador. Postmenopausal osteoporosis is considered a serious public health problem because it has prevalence worldwide. Approximately 30% of postmenopausal women, and the United States at least 40% of the women will have one or more bone fractures during their lifetime. Video.
Menopause is a typical patient in my practice, and the common questions that I hear are, how much longer will this last? Hot flashes, sleep disturbance. Will hormones help all of my symptoms? It's always a bit of a loaded question, because when I see all or nothing, I usually can't say it'll help all of your symptoms, but we'll talk about which ones it might help the most. And then what are the pros and cons of using hormones? That's a great question that we'll get into in more of a discussion. No great answer to that. It's very individualized. But what are the causes of hot flashes? It's actually quite complex, and some people could give a whole talk on the etiology of hot flashes. It's not all about estrogen. There's probably other things that happen during menopause, because not all women who go through menopause have hot flashes. We think there probably is some central nervous system activity that's related to menopause. And deep in the brain, there's a thermoregulatory zone. And some people have done basal body temperatures and have actually found that women who tend to have more hot flashes have a more narrow thermoregulatory zone. And because estrogen is not the only thing that affects that thermoregulatory zone, there are neurotransmitters that can affect that. That's why it's not all about estrogen, and some of the alternatives to estrogen have to do with some of the neurotransmitters that are in the brain and in this thermoregulatory area.
Conclusion. Despite the significant advances made in the diagnosis, prevention, and treatment of postmenopausal osteoporosis, the disease remains an important socio-sanitary and economic problem. But that to the drugs Romosozumab increase bone formation and reduce bone research will help scientifically reduce the risk of the fracture, accompanied with healthy and balanced video.
So, at the ACR, Representative Coaster had described the paradigm from the phase 3 landmark trial. This trial was actually head-to-head with teriparatide, the currently approved anabolic agent in the United States. We also had a placebo. It's interesting that even though we were head-to-head with another anabolic agent, we actually had better increases in BMD at cortical sites, such as the total hip and the femoral neck, than teriparatide. We also had a reduction in new morphometric vertebral fractures. Teriparatide also had the same reduction as we'd anticipated. However, when it came to non-vertebral fractures, and those are very important fractures because they include hip, wrist, tibia, places that